Hello, my dear future doctors. Hello, Bazel. How are you?
Hello, Doctor. I'm fine. How are you?
Fine, thank you. Uh, Thanks God, my chief and his wife are back, so I can afford one day to be home after a stressful 2 weeks of his absence. Now I can finally be home, conduct lecture with no hurry. Uh, Yeah, and we are going on surgeries as well, because the government has gave us notice that oncology, like brain tumors, are not postponed. Surgeries for that are not postponed. Just the planned surgeries like plastic surgeries, cranioplasties, and so on. Just that kind of surgeries are postponed. So we are still continuing with the emergency surgery and with oncologic part as well. Okay, I will wait a few more minutes. I guess Philip's gonna join us, and Cookie. They are all always here, so I'm gonna wait for that. Hello, Philip. How are you?
Doctor, uh,
Yes.
I asked you in the past about the first midterm that if it will
Yeah.
be cases or not. You said it will be, and I see none.
Yes, I decided not to because it was just the basic part, basic pathology. Now, yes, now there will be cases because we are already studying pathologies. So it was just the definitions, and because the material was something like doesn't we didn't study many of the pathology, but this book is made up of all pathologies, so that's why I can give you cases, and that's why in my presentations are also including cases, because for you to be easier to recognize the cases as well. Hello, Philip. I'm well too, thank you for asking. um as you can see, I'm finally home, so I can have I can afford a Tuesday to spend in my house because my chief and his wife are back, and I don't have to run in the middle of the lecture anymore. Okay, so I will just quickly open up the schedule syllabus for you, because I've been getting mails and questions about the midterm materials. So as again and again. I'm doing this for hundredth time, but again, for those, I hope they will watch the video lectures. Okay, so this cell injury, adaptation, inflammation, hemodynamics, we did in the first midterm, and these were the topics that are just basic pathologies without any disease. Okay, not many disease, but some of them were included. So this was the part of the first midterm. The second midterm will include disease of immune system, inflammatory and reactive disease of oral maxillofacial region, which I have with the cases, obviously, hyperplasia, hamartomas neoplasm, benign epithelial tumors of mucosa, premalignant and malignant, which we have discussed in the last week. And on Saturday, we talked about neoplastic salivary gland disease, and today we're going to talk about salivary gland neoplasms as benign as malignant. And last topic that will be included in the second midterm is genetic disease, which I'm going to discuss next Saturday. Okay, so next Saturday I'm going to discuss genetic disease, and we will have already discussed all the material for the second midterm. So I will go on with the odontogenic fibrosis, neoplasm of immune system. This is for last 3 weeks material. And by the time you have a midterm, you will already have discussed all the topics for the second midterm. So, and again, it's going to be with the cases because as well as in my PPTs, you can see that there are a lot of cases. Okay, so you can use them to help you, to guide you, and to identify the similarities between the differential diagnosis between the different disease. Okay. All right. Oh, but that doesn't mean you shouldn't read the book. So you should definitely read the book, which is Marx and okay, I'm gonna show you the book as well because unfortunately some of your friends or mates have also been asking me about the book, and by this time you should all have downloaded it. So this is this is the book I'm talking about, Oral and Maxillofacial Pathology by Stern and Marx. Okay, the 1,000-page book. This is in 2 parts actually, and you should search for the pathologies we are discussing because the I'm not actually giving you the pages, so it's up to you to write to find the right pages for the right pathologies. Okay, additional work you have to do. Okay. Okay, hello guys. Welcome Diana, Cookie, Philip, Vazel, and Ahmed. Welcome to the pathology lectures, and let's get started. Okay. In a few minutes, I've given you the idea about the second midterms material, and also I said that we're gonna have cases in the second midterm. The second midterm is gonna be a lot more difficult than the first one. The first one was really easy because it included just the general terms, general definitions, and the material was not that hard, and the material was small as well. Okay, because one chapter was divided for 1 week, and that's a lot. But for this part, we have a limited time and a lot of material. Okay, yeah, and about histologic parts, I know it's a lot. It's easy to confuse each of the disease with each other, but I'm not asking you to memorize everything. I'm just asking to memorize the key parts which will help you, which will guide you to the correct diagnosis. Okay. So today we're going to talk about salivary gland neoplasms. Yeah, in the previous lecture we talked about the non-neoplastic lesions of the salivary glands, like pre-malignancies as well, and hypertrophies, hyperplasions, and benign swellings, parotitis, HIV parotitis, mumps, and so on. Today we're going to discuss tumors which could be benign, like pleomorphic adenoma, myeloepitheloma, Barthen's tumor, basal cell adenoma, and not all of them, but the ones that I consider to be most important because there are a lot of them, you see. And the malignant tumors like mucoepidermoid carcinoma, central carcinoma, acinex carcinoma, epithelial carcinoma, salivary duct carcinoma, and so on. Okay, as you can see, a lot of things we have to cover it for today, but I've chosen the most important pathologies and most important cases and most common that you're really gonna miss during your practice. Okay, Okay, let's start with benign salivary gland neoplasm, and the first one to go is pleomorphic adenoma. Pleo means many, morphous means body, so it has many forms. Actually, it doesn't. It's a tumor. It's a benign tumor, adenoma, and all the tumors, the benign ones, have in common the suffix "oma." Okay, but there are some rare exceptions like melanoma, which has a oma as a suffix but is the rare malignant tumor. So oma shouldn't get you mistaken, okay? But in case of adenoma, it's a benign tumor, okay? So, pleomorphic PA, so you're gonna omit the abbreviation in the literature, PA, so pleomorphic adenoma is a well-defined tumor that is characterized by its pleomorphic or mixed appearance. That's where the name comes from. Okay. It's the intermixing of the clearly recognizable epithelial component with the mucoid, myxoid, and chondroid component. Let's see, there's a cartilage as well. So not just epithelial, mycoid component, myxoid component. So it's a mix-up of the cells that makes a pleomorphic adenoma. Okay. Incidence increases from 15-20 years after exposure to the radiation. So radiation is the carcinogenic factor that increases the incidence of the pleomorphic adenoma. Okay, it's usually associated with the simian virus 40, yes, and virus. So you know that human papillomavirus is also associated with the malignant tumors, while polymorphic adenoma is associated with the simian virus type 40. Okay. So it's usually asymptomatic, as you can see here, but mass is quite noticeable. And pleomorphic adenoma has a glandular origin. It is usually located in the head and on the neck region, and usually manifests as a mobile. It means it's not attached to the underlying skill. It's a movable. It's a mobile, slow progressing, and it's growing slowly because it is benign. All the benign processes usually grow slowly. Asymptomatic because it doesn't usually give a pain, so it's painless, asymptomatic growth, slow growth, and firm in consistency and mobile, that doesn't cause ulceration of the underlying mucosa. Again, one characteristic of the benign lesion. Parotid gland is usually the place for the pleomorphic adenoma, as you can see in this picture as well. Um, yeah, and below the ear and overlying the angle of the mandible is the favorable place for the pleomorphic adenoma to be located. And facial nerve paralysis or plagiar weakness is an infrequent sign in parotid tumor. Usually it is asymptomatic, but if the mass is huge enough, is large enough, it can compromise the facial nerve. So it can compress it and cause the facial asymmetry, palsy even. Okay, so let's see the case for that. We've got a 50 years old female patient reported with the chief complaint of slow growing, painless swelling on the left side of the face since 5 years. So it was really slow. For 5 years, she didn't came to the specialist. The swelling was initially small in size and had progressively increased with time to attain the present side. And we're going to see in the next slide. Past medical and surgical history was not contributory. After all, clinical examination revealed the marked facial asymmetry, so it means the facial nerve was compromised. A well-defined, ovoid, multilobular swelling glandular structure. You remember? Now, on the left side of the face, swelling had the superinferior intent for the left segment. So I'm going to just show you. and that is it. Yeah, she doesn't look like 50, I know, but that's, yeah, some of, yeah. This is the mass that I was talking about, glandular, and she grew this one for 5 years. This body is 5 year old. So there is no ulceration. I see the small ulceration here, but again, the skin is so stretched. It has no good blood flow. Blood flow is also compromised, and there is no question mark why the facial asymmetry occurs, because this kind of huge mass can definitely compromise any nerve, especially the facial nerve, which is very how to say, vulnerable. Okay. And the swelling has firm and consistent. It was firm in consistency, non-tender. Maybe that's why she didn't go to the doctor, because it was painless. And the warm palpation, warm because all the tumors have a lot of blood flow in them. That's why they grow so huge, because they have a neoangiogenesis. It means newly formed blood vessels are there, and they're supplied well with the blood. So it was fixed to the underlying structures and the underlying skin as well, and facial and eye movements were normal on the examination. That's all. Intraoral and a clinical examination was unremarkable. Nothing in the inside surface of the mouth. Pleomorphic adenoma was the first consideration, but also the differential diagnosis included Warthin's tumors, Warthin's tumor, which we're gonna see further, neuroma of the facial nerve, so nerve sheath tumor, because of the obvious location. Okay, and these are also probable differential diagnoses were considered. And this is the MRI. As you can see, the mass is huge. L means the left part. So this is the TH, and this is a different contrast, the one. So it means blood supplied, well, blood supply is a huge mass. And this is the during the surgery. Yeah, huge glandular mass composed of the different epithelial, myxoid cells as well. And it was en bloc excised. It means without destroying its entity, so the whole thing. And here you see blood vessels and nerve fibers, okay? They should be delicately removed from, okay? And that is the mass, the mass that weighted, oh my god, it's a huge, yeah, weighted a lot. And measurements, you can see this like a potato, yeah, the big one. And that is what histologic findings gave us. So adenoma, it means they are glandular cells, epithelial cells, mixed cells, and the histologic diagnosis was the final. So it differs it from Warthin's tumor or from nerve sheath tumor, because definitely adenoma was the tumor. That is the post-surgical picture. Very nice, right? Healed nicely. You don't even see the scar because it's below the jaw here. And this dark pigmented skin is because the mass was compromised the blood flow to the skin. But it will come to the senses later. It will just gain back the coloration, I hope. But after what she had, and that's the list of her concerns, I guess. Okay, so that was one pathology with its own case. So let's see the second one. It's myoepithelioma. Oma again determine the benign process, and myo means there are not just the epithelial cells involved, by myocytes also. Okay, okay. So the parotid gland and the to a lesser extent glands in the palate are the preferred locations for myoepitheliomas. There is no specific clinical features that distinguish them, and they are usually present as a slow-growing, plainless masses, but the location gives them up. Okay, so myoepitheliomas of the parotid are usually encapsulated lesions with no ulceration. There are four types, mainly four types. There's spindle cell, hyaline, plasmacytoid, myeloid, clear cell, and oncocytic. So there are four types of myoepitheliomas depending on the cell, usually. An epithelium component should be less than 5% to 10%, and fibromyxoid stroma should be absent in case of myoepitheliomas. Okay, so this is the favorable place, hard pellets, maybe the junction of this hard and soft pellet here you see, and this is the morphology findings of my epitheliomas, and usually they're excised with the small excision and just taking them out. Okay, so that's it with the myopitheliomas. They're not though that common. So let's talk about the Warthin's tumor instead, which is second most common benign lesion of the parotid area of the mandibular angle as well. And we remember the case. So differential diagnosis between pleomorphic adenoma and Warthin's tumor is important. That's why you should know what is Warthin tumor. It is commonly arising in the parotid gland, the most commonly. It's encapsulated and composed of the solid as well as cystic areas with two key components. First one is bilayer of oncocytic epithelial cells that develop cystic structures, and plus papillary projections with increased amounts of mitochondria that are densely packed, showing abnormal size and the shape. So mitochondria could be histological findings during differential diagnosis. And the second component is the stromal component of the lymphoid tissue that contains germinal centers. Lymphoid tissue plus mitochondria with papillary projections on oncocytic epithelium, that was makes up a Warthin's tumor histopathologic picture. Okay, that what makes it easier to differ from the others via learning the tissues, okay, at the microscopy level. There are two main theories that exist about the origin of the Warthin's tumor. As they contain lymphoid structures, there is a thought that they are somehow the result of immune or hypersensitivity reactions. Okay, so hypothesis of heterotopia, which says that the lack of parotid capsule early in the development results in the ductal elements become entrapped within developing lymphoid tissue, and that gives the rise to the Warthin's tumor. The other thought is that adenoma with associated lymphocytic infiltration suggests that there is an immune or hypersensitivity reactions to the epithelial cells present within the Warthin's tumor. Okay, so that's the case. We've got the 71-year-old Hispanic male referred for a 2-month history of dysphagia. Dysphagia, what it is? This means disturbance. Phagia means eating. So it is disturbance between, so it's an ability to swallow, okay, to swallow food, solid subjects, okay, or to drink, to swallow water, okay. Yeah, inability of swallowing. And the left oropharyngeal fullness in early 2014. And his past medical history was significant for hypertension, for dyslipidemia, arterial fibrillation, Warthin's tumor of the left parotid gland, and in the 2008, for which he received the left superficial parotidectomy and developed Frey syndrome. You know all that, right? So the Frey syndrome, yeah, develops iatrogenic, so it means a post-surgical syndrome, disturbance of the nerve roots, and sweating this part. The after the superficial parotidectomy, it means just the part of the parotid gland was resected within the tumor, but it is almost impossible to differ the tumor from the healthy tissue. So the part of it was still left, so it could give the rise to the yes. Recurrency, yeah, possible. So he was currently smoking with a history of the 27 5-pack years, and the physical examination was significant for the left oropharyngeal soft palate fullness without the ulceration. So that's what you see. So this act the tumor, no doubt. The tumor of the left part. So this is the right, this is the left, this is the tumor, and here is the tumor as well. Okay. Again, this is oropharyngeal part. Why the swallowing? Because of the mass compression, and that's they took the biopsy. They did the this is the morphologic findings during the Vertins tumors. Lymphoid tissues are easily noticeable, and stromal part you see, and parenchymal part you see. That's how the Vertins tumor morphology looks like. Okay. So it was the recurrent Warthin's tumors. Okay, it is benign process, but it can reoccur if it is not radically removed. So partial parodidectomy was the reason it reoccurred, and plus the patient was smoking and carcinogens, a lot of and the nicotine and smoke, and that increases chance of recurring tumor. Okay, maybe that's this time it will get malignant. It has a tendency to malignancy as well. Recurrency defines malignancy as well. Okay. So now another benign neoplasia is the basal cell adenoma. We know pleomorphic adenoma, which contains many different cells, and adenoma, which contains only and only basal cells. Basal cell adenoma. This is the neoplasm of the uniform population of the basaloid epithelial cells, classified as monomorphic, not pleomorphic in case of pleomorphic, because it contains different types of cell. This one contains only one type of the cell, basal cells. That's why mono means one. One type of the cells are involved. These intercalated duct or reserve cells is the histogenetic source of the basal cell adenoma and occur primarily in the major salivary glands, not the minor ones, but the major ones. Okay. Sorry. I hope but still syphilis as always. It is slow growing, although the majority of the numerous benign processes are slow growing. Again, asymptomatic, so it was painless, and the freely movable, so mobile mass, firm swelling that may be cystic and compressible, making it indistinguishable from mixed tumor, which is pleomorphic adenoma, or even Wharton's tumor. So that's why differential diagnosis should include those two as well. So you see here the quite young patient. This is the swelling of submandibular area. You see here, visually visible. And this is the exposed so tumor, you exposed mass, as you can see from overlying skin. And that was the MRI or CT. This is CT because you see one see. This is the mass and this is the mass. See the mass here. Okay, and this it was excised. As you can see, it's 3 centimeters in the length, maybe 2.5 in the width. Okay, quite huge for this area. So it's a 23-year-old female patient reported with a chief complaint of the painless swelling in the right submandibular region since 7 months. So slow. Extra examination revealed a well-defined ovoid solitary swelling in the right submandibular region measuring approximately 3 centimeters. It was normal skin color, non-tender, and moderately firm in consistency in the first figure. And the swelling moved on the gluteation without any pulsations. Okay, not blood supply. Okay. So that was basal cell adenoma, remember. we've got carcinomas as well. And another type of adenoma is canalicular adenoma. As you can see, the canals of the nerve root, you see. This is uncommon, benign salivary gland neoplasm of the minor salivary glands derived from the terminal duct origin. So duct, terminal duct origin. The neoplasmic cells were a relatively monotonous isomorphic population of the high cuboidal to columnar cells, and 1-2 cell layers thick arranged in anastomosing, branching, or budding cords, tubules, rows, strands, columns, or canalicular. So canalicular adenoma. That's how it looks. That's adenoma. That's adenoma. Adenoma. Okay. That's all you need to know about canalicular adenoma. I got no case for that. Okay, and here we have, let me check this out. Okay, I can wait. Oncocytoma. Oncocytoma. Again, this is also a benign tumor, but sounds like strange, right? So it's a benign epithelial tumor, most commonly occur between the 6 to 8 decades of the life, so 60, 80 years old, with a slightly higher incidence in the female population. They often present as solitary, slow-growing, painless masses which are firm, multilobulated, and mobile entities upon clinical examination. A computed tomography, magnetic resonance imaging, MRI are the image modalities of the choice. Okay, and here we have the case here. 68, 60 to 80, as I said, a male presented, but female would be better. Presented to the service with the left facial swelling, so left one, this one, a swelling of the 5 month duration. His medical history was unremarkable. He had no pain or cutaneous inflammatory reaction. An intraoral examination revealed swelling of the soft tissue palate, and CT MRI imaging studies were performed to identify the nature of the swelling. Yeah, there is a mass here, and the swelling is over it. Oh yeah, that's a huge mass here. Okay, and yes, that's a mess too. Yeah, you see different contrasted versions of MRI and CT. Yeah, this is also. This is you see the tooth, and here you see the mass, which is slightly more in the left, but it's, you see the midline is shifted. The midline should be here, but because of the mess, it's shifted to the right as well. And that is the intracervical view. It's tucked, and all the nerves, all the vessels are exposed here, and this is the mass. It's quite a dangerous place. Okay. Yeah. I don't have, unfortunately, I don't have a poster of pictures, but quite beautiful intraoperative picture. Okay, so that was it. Well, let's see the CL adenoma papilliform. So adenoma, again, salivary gland benign tumor, but CL, when we're saying that, yeah, salivary gland, definitely. Papilliferum, it means the form of the papillary form. Okay, it's a rare benign salivary gland tumor that most often arises from the oral minor salivary gland, especially on the palate. And the tumor is so named because of its microscopic resemblance to the syringocystodenoma papilliform, an uncommon benign tumor of the sweat gland origin that has a predilection for the scalp and forehead. So it looks like this cystadenoma papilliferum, and papilliferum comes from that word. Actually, it is cell-adenoma. Okay. Let me take this one. Sorry. Алло? Какие марчат? დიახ, მითხარით, რა გაინტერესებთ? დიახ. ფილებს სხვა აგრძელებს ჩვეულებრივად. ფილებს სხვავს ჩვეულებრივად, კარბამაზებინს. ალო, გამარჯობათ. დიახ. კი ბატონო, დექსამეტაზონი კრუნჩხოსთან არ არის კავშირში. ფილებსინს თუ სვამს, ფილებსინს. კი. დღეში 3-ჯერ 200 სვამს. ზომ არ ჩაგვიგდია და დრო არ დაგვიგვენებია, ხო? არა. კარგით. არაუშავს. დექსამეტაზონი გააგრძელეთ. დექსამეტაზონი არ არის კავშირი, გუყრათ არის კარბამაზეპინთან. ანუ დექსამეტაზონი კლებითი შევამცირეთ. 2 დღე აკეთებდით 4 სავს, ხო? ხო. კი ბატონო. შეგიძლიათ თითო გააგრძელოთ კიდე 2 დღე, მაგრამ მე დიდ კავშირში არ არის გუყრასთან. იგი უნდა გადაიღოს, შეიძლება ეპილეპტოლოგმა შეიძლება რამე დამატებით ჩათვალოს დამატება. დიახ. ამ წუთში არ ჭირდება, თუ ცნობიერება დაუკარგათ, თუ თავისით შეწყდა და დასრულდა ეს გულყრა, არ ჭირდება არაფერი. შეიძლება განმეორდეს, მაგრამ ფილებსინი დროულად დაალევიეთ, არ დააგვიანოთ, ეს ინტერვალები დაიცავთ. კარგით. დიაზეპამი გქონდეთ მაინც? ალო? არაუშავს. დიაზეპამი გქონდეთ მაინც სახში, რომ გენერალიზებული რო დაემართოს, თქვა გონებაც რო დაკარგოს და ხელფეხშიც გადავიდეთ. დექსამეტაზონი არა, ჰორმონია, გულყრის საწინააღმდეგო დიაზეპამი. დექსამეტაზონი აღარ გჭირდებათ. კი, ანუ თუ ეტყვით, ან შეიძლება მით არის, რა ქვია, დანიშნულებით არის. დანიშნულებაში არ გვიწერია, მაგრამ თუ ეტყვით, რომ სიმსიმეა, ერთ ცალს მოგცემენ აუცილებლად. კარგით. Sorry, guys. Okay, sorry. Comprised of a papillary epithelium component that resembles squamous papilloma, combined with the subjacent unencapsulated salivary gland ductal proliferation that is contiguous with the overlying papillary squamous mucosa. So that's the as you can see, majority of the cell adenoma is located in the minor salivary glands on the palate, and that's a histомorphology picture of this. It looks like vertins, but actually it's not. Okay, and here we have inverted ductal papillomas. Inverted, it means, yeah, as the word suggests, inverted one. You see the excavation here. So it's a benign tumor that is located in the secretory duct of the salivary gland. Histological similarity to the intraductal papilloma is quite similar, which is known in the sinonasal, nasal, in the bladder, and in the oral mucosa as well. Okay, papilloma, which is inverted. Let's see the case. So the 40-year-old Caucasian woman was reported to our service and oral surgery for the evaluation and treatment of the tumor located in the lower left lip mucosa, which is not so common place for the She had the habit of the nibbling her lower lip and had suffered trauma in the same region upon impacting with the head of her young child. After 3 months, the patient noticed slight changes in the size of the lesion. She appeared to be in a good health and no maxillary asymmetries or tumors or neck adenopathies were detected. And that's how the lesion looked like. The slight swelling, nothing significant actually, but there is a swelling here. And the differential diagnosis should include traumatic hyperplasias as well, right? So at clinical exploration, the lesion showed a nodular aspect, soft consistency, no adherence to the deeper layers, and no pain in response to. There were no signs of inflammation or separation or affected zone, and the rest of the orofacial structures were normal. The X-ray study reviewed no alterations because there is no bone formation that for the X-ray to review. And differential diagnosis included pleomorphic adenoma, which we can meet on the lip, a traumatic fibroma, and lipoma. Okay, but the surgical diagnosis, the histology diagnosis defined the final diagnosis. Okay, okay. I guess we can have a rest because we have gone through all the benign processes. Now I can give you a 10-minute rest, and today we're gonna finish quite fast. Okay. See you in 10 minutes. Do you have questions? Maybe was everything clear to here? Oh, I hear no questions. I guess everything was clear. Okay, see you in 10 minutes. Okay, my dear future doctors, um, my beautiful young friends, let's get back to the lecture. Okay,
Doctor,
yes,
is the presentation is enough for the second midterm, or should we study from the book?
from the unfortunately, it will not be enough because there are some questions that are only in the book, but that I have not included in the PPTs. But the cases will be similar to the PPTs, okay?
Mm-hmm.
Okay, thank
But
you, Basil, for the
it's
question.
impossible to study to cover all the materials
I
from the
know
book.
all the materials, but at least those that are not included in PPT. Okay, those that are in PPTs, I will try to just make the questions from PPTs. But those that are not here, um, please, you have to
Can
cover them
you
in the
tell
book.
us what to focus on from the book?
Yes, before the midterm, 1 week before the midterm, maybe next Saturday, I will give you the pages in the
Mhm.
book. Okay.
Thank you,
Mhm.
doctor.
Thank you, Bazel. Thank you. Okay. Mm, let's go on with the malignant salivary gland neoplasm. And the first one, they are called carcinomas. Carcinoma, it has oma in the suffix, but that doesn't mean a benign process. It is 100% malignancy carcinoma. Okay, so mycoepidermoid carcinoma is the most common mucoepidermoid, if you can say that. It's originated in the minor salivary glands, and it compromises approximately 10 to 15% of all salivary gland neoplasms. And most common malignant salivary gland, as I said, tumor, and usually affects the parotid and minor salivary glands of adults as well. And this is the morphologic findings of the mycoepidermoid carcinoma. Okay, it's slowly enlarging, painless mass of the several years duration, usually, and clinically mimicking pleomorphic adenoma, the first pathology we have learned today, and other benign neoplasms. But that's very important to differ them from each other because carcinoma is a malignant tumor and it couldn't be left without surgical excision, without proper treatment, okay? Because it could go down to the bone and then it will be possible to fix the process it will leave after. So pain or facial nerve palsy may develop. So it's no longer asymptomatic or painless. Pain is also possible, and facial palsy due to the compression of the facial nerve, and usually in association with the high grade tumors. Let's differ low grade and high grade. So low grade malignancies is characterized by slow growing, painless swelling with a rarely exists which rarely exists 5 centimeters, so it's limited in the area. Okay, while high grade is usually rapidly growing, very fast growing, still painless, but infiltrate into adjacent tissues, no longer 5 centimeters, but infiltrates in the neighboring tissues and are associated with the distance metastasis. Okay, so somewhere else could have the secondary tumor. Extraoral ulcerations are also possible. That's why they should be tended accordingly. Okay, so let's see the case here. So as visually, you also can differ them quite well because they are different looking ones. We have a 21-year-old man presented with a 2-month history of the swelling his lower right back teeth region, and the swelling was insidious in onset, so it started suddenly and had gradually grown to its current size. The patient had a 15-day history of the pain, which was sudden in onset, dull and continuous, and was worse while eating food because mechanical contact made it worse. And his past medical, dental, social, family history was unremarkable. as on intraoral examinations, solitary well-defined oval-shaped erythematous swelling was found, and medially it extended to the depth of the right lingual vestibule laterally into the right retromolar. So as you can see here, not just here, here also you see this lesion. It's a two-part lesion. And the surface of the swelling was depressed at the center, mimicking the sinus tract, and was irregular in everted margins, and the swelling was softiform and was tender on palpation associated with the bleeding. So it was somewhere here. Sorry. Somewhere here, right? Located somewhere here. And yeah, this is the place. This is the CT. You see the bones of the teeth here, and that's the place. So the measurements are like 1.6, 1.2 centimeters. Okay, differential diagnosis includes, as I said, pleomorphic adenoma and other benign tumors of the salivary gland, as well as secondary malignancies in the jaw bones, and also suggested metastatic tumors. But the final diagnosis is usually after the surgery. Um, as you have a thought that this could be, there is a chance of malignancy, you should as radical intervention as possible. So it means excise the whole lesion within the margins of the healthy tissues. And you see the depth of this is the necrotic ulcerated part, and this is the intraoperative picture you see here. And this is the lesion they excised. It's approximately 4 centimeter. So this is the center, the actual mass, and this is the within the margins of the normal tissue. This is the second part of it. Okay, they excise it totally out of the, and this is how they close the flap. So this is uh there is a space left after the excision, so they should close it with a flap. And so they took a tongue's part surface, they prepared it, so called, like this. They prepared the surface and took it this flap to close the lesion. Okay, sorry, I'll show you one more time. So before the surgery, they drew the margins, they subtracted a tongue out, then they prepared the surface. This is the flap to cover up the defect, what is left after the surgery. So tongue is deviated, and this is the flap, tongue again, and the flap that closed down the defect that was left after the cutting out the malignancy. Okay, this is the flap, and this will heal afterwards in no time because the mucus always heals. Okay, that was the case. So aside from the other carcinomas, we've got central mucoepidermoid carcinoma. So what is it? It's just a mucoepidermoid carcinoma, just like the previous one, but it's called central one because it's usually is located on the palate. Okay, most commonly occurs in the 4th to 6th decades of the life with a slight female predilection, so female gender, and involves the mandible 2 times more often than the maxilla. So lower jaw is more frequent to be involved. In children, the incidence is almost equal in both maxilla and mandible. The most common site of occurrence is the premolar molar angle region of the mandible. So let's see the case here. So you see there are toothless parts, and this is the left lower jaw, so mandible. So this is the favorite part for the central mucoepidermoid carcinoma. It's associated with mandibular cysts in half of the cases, as the tumor shows a tendency to crop up at puberty. Hormonal influence of the salivary glands was suggested as an etiological factor. So that's why it usually starts during the puberty. Okay, so it's painless swelling of the jaw and the most common presentation painless and the occasional presence with the pain, paresthesia, numbness, and the loosening of the tooth, which is what you see on this X-ray panorama of the jaw. Okay, that's the case. We have a 56-year-old patient reported with the chief complaint of the pain and swelling in the lower left region of the jaw since 1 year. Pain was dull and intermittent in the nature and was localized. Yeah, left jaw. The patient was apparently asymptomatic in 1 year back, and then he noted bleeding from the lower left back tooth region. So the bleeding, erosion, ulceration. Patient personal history revealed that he had a habit of tobacco chewing, so we've got cancerogen here, and carcinoma is most likely to occur for 30 years, since 30 years, and now he is 56. On extraoral examination, a firm swelling was present on the left middle third of the face, round measuring about 3 centimeters to 3, and the swelling was not tender, with no change of temperature of the overlying skin, and the left submandibular lymph nodes were palpable, slightly mobile, and tender. Usually, that is the feature of the malignant process, okay? When the lymph nodes are palpable and tender. Remember that. So, orthophotogram and the computed tomography with three-dimensional reconstruction followed by excisional biopsy were advised. Under general anesthesia, it means the patient were asleep. A partial mandibulectomy on the left side was done and the specimen was sent for histopathological examination, which confirms the diagnosis, and the reconstruction was done after that. So this is the 3D CT. You see the whole bone here. Here, here, here is the mass. And that's the surgical, sorry, the left one, okay? So let me show you once more this part, this part, this part, again, this part. Here, you see the emptiness here. So the bone is destructed. Here you see destruction of the bone and lack of teeth. See here, emptiness. Yeah. And that's intraoperative picture. So this is the submandibular incision, and this is the mandibular jaw, and this should be removed because carcinoma is infiltrated in the bone, bony destruction, you see. But without removing this part, it will go again, so recurrence will occur, and even worse, metastasis can be, and this could be fatal, okay? So removing the bone within the margin, this is this part, you see here, they've cut this part, and this is the cancer that infiltrated the bone, okay, destructed the bone and infiltrated. Okay, unfortunately I don't have post-surgical ones, but it will look beautiful after sewing up, but empty. Yeah, maybe they will do the plate reconstruction, right? Adenoid cystic carcinoma is the next one. Adenoid cystic carcinoma, ACC. Sorry. Let me quickly see it. So it's a rare malignancy, and approximately 10% of the adenomic cystic carcinoma occurs in the salivary glands, and among which adenomic cystic carcinoma of the minor salivary gland has the worst prognosis. Generally, an irregular margin is found in a high-grade salivary gland malignancies, where a well-defined margin is found in the low-grade salivary malignancies and benign tumors. They have no capsules that are detectable by MRI, so they are not encapsulated. At least MRI cannot see it. So, but the histologic picture is quite remarkable, and you cannot mix it. Not maybe you, but the experienced histologist cannot actually mix this picture with others. So, It's adenoid part, the cystic parts in here, and the carcinoma. So differential diagnosis of the lesions originating from the sublingual glands includes pleomorphic adenoma, actinic cell carcinoma, mucoepidermoid carcinoma, which was the first one we discussed. Okay, let's take the case. A 58-year-old male patient was referred for the treatment of the slowly growing swelling in the right side of the mouth floor that had been present for 1 month. He had slight dull pain during eating and spaying, and the patient stated that the size of the mass changed several times a day. And he had a history of the smoking and alcohol consumption for more than 30 years. And so no other specific medical problems were detected, and he had no history of traumatic injury, invasive surgery, bleeding, or discharge. He had no family history of the cancer as well. So let's see. Oh, sorry. Oh, I don't. Maybe I should add. Sorry. This one should be first. Let me add a animation like this. Okay, I think we're good. Okay. So, no, we're not. Oh, yeah. Yeah. Okay. Here we see the mass under the tongue. You see, this is a mass. And somewhere here should be. Yeah, but it's not seen on the X-ray. So intraoral examination showed that the mass of 3 centimeters and legs 2 centimeters was covered with the intact mucus without the ulceration. The adjacent teeth and gingiva showed no abnormalities, but there was a mess. So in a dental panoramic view, only chronic periodontitis and the several retained dental roots were found. No bony irregularities or cellulitis were found. So this is the CT in this case, and this is the lesion. See here, you see here, no bony lesions were. This is just an error. No bony lesions were found, and this is after excision. You see. This is what is excised, and this is cut in half, and you see the structure, how it looks like in the middle. So in the middle, you see the necrotic parts because usually blood supply is well in the outside, but in the middle it cannot reach well. So it starts necrosis within the middle. Okay, necrotic parts are located inside. Outside is well supplied, and that's why it grows big. Okay. So let's see the salivary duct carcinoma. All the structures that are located in the mouth and in the oral cavity can have the carcinoma, especially salivary ducts. Okay, CDSDC is a distinctive and clinically aggressive adenocarcinoma of the salivary origin, and it arises from the ductal epithelium predominantly occurring in the major salivary glands, especially parotid glands. So you should differ from the benign processes. The first thing to do is to exclude the malignancy. Okay. So let's see. This is the last case. I promise. Yeah, it doesn't look great, right? It doesn't look like a benign at all. So it's a huge mass with the skin over it is red because it's stretched so much, and it has disturbed blood flow as well. So you see this glandular part because it's so many lobulated parts. So it's a 25-year-old. He's an old male patient reported to the Department of Medicine with the chief complaint of the swelling of the right side in the face and the neck as well. You see, the neck part is involved. 25. The patient had noticed the swelling 7 months back in the right parietal region with a small in size. 7 months and it grew this huge. That's quite rapid growth. Since when the swelling had progressively increased in size, and since then, and there were no history of the bleeding or pain associated with the swelling, maybe that's why he waited for 7 months. Passed with a huge mass on hanging on there. Her past medical history was not significant. Okay, and this is the CT you see here. Yes, the crazy huge mess hanging on the face and the neck of this 25-year-old male. On the palpation, swelling was found to be not tender, soft to firm in consistency, non-fluctuant, it means no abscess or something, not compressible, and non-reducible. So you couldn't, it was firm because you couldn't compress it or reduce the size. Temperature over the swelling was raised because you see that it was red and it is easy to define, but it was hot as well. So the right submandibular lymph nodes were enlarged. Oh, that's never a good sign. And firm and tender on palpation. So that one thing that also suggests the malignancy. Intraorally, there were no abnormality detected related to the swelling, just extra well. So what was done? It was surgical resection because you cannot leave that thing on his face. Surgical resection of the parotid tumor along with the skin and lymph node dissection was performed because you shouldn't leave lymph nodes as well because they could be metastasis parts of the tumors. It could grow bigger. So this is the mass. Yeah, yeah. Whole man sitting there. And when you cut it inside, you see this the picture of carcinoma. So death inside it. Okay. Yeah. Thank you. That was it. The unfortunately I have no also pictures that just this part. Okay, but still impressive, right? Okay. Thank you very much. And yeah, winter is here. I hope you are ready to dress warm, eat well, sleep well, and read because you have got lots of material in the book, and you should be prepared for the second midterm because it's within 2 weeks, and 2 weeks it's not that much of a time. Okay. Thank you, Philip. Thank you, Cookie. Thank you, Ahmad. Mm, we have lost some friends during the presentation. Thank you, everyone. And yeah, see you on Saturday, Philip. Bye bye. Thank you very much. I hope it was interesting. Thank you, Cookie. Thank you, Ahmad. Thank you, Philip. You also have a nice week ahead of you. See you on Saturday. Bye bye.